All of my patients receive a TKI in the frontline setting, and when I'm convinced that that's no longer working, I have to decide whether another TKI or a checkpoint inhibitor is the appropriate approach. In my own view, the trials that have been done don't help. So what I'm thinking about for my patient is the quality of life, their time on treatment, how they're going to feel, the side effect profile, and the outcomes. So with nivolumab, I know that I don't have the ability to produce a progression-free survival benefit, but I do have the ability to produce a survival benefit with the possibility of a bit of the tail of the curve. And I also know that patients feel better on nivolumab. They come off of their TKI, they realize how much TKI side effects they were having, and they feel better. I also know that I have cabozantinib and lenvatinib everolimus should nivolumab not be helpful. But I do use cabozantinib in select patient populations because of the recent subgroup analyses, especially the subgroup analysis showing that there was benefit for bone metastases patients. I tend to be seeing a lot more patients with bone metastases these days. It may just be just what I'm seeing, and it varies. But there is some evidence through MET and AXL that patients with bone metastases might benefit from a MET inhibitor. So in my patients with bone metastases, I tend to start them on cabozantinib and then use nivolumab in the third-line setting. My integration of lenvatinib and everolimus has really not penetrated the second and third line as yet, but I know that I have it there after cabozantinib and nivolumab have been tried, and if they don't work, I have a fourth option.